Chest pain is one of the scariest things that we see in the hospital, but they're not all created equally. It could be as simple as something like palpitations or heartburn, but it can also be something very serious, life-threatening that could potentially end your life. So in this video, I'm going to talk about the 5 most common reasons that someone comes in with chest pain from a perspective of a cardiologist. This is very important because it can be treated as something as simple as relaxation methods, Tums, or if not treated appropriately and you ignore these signs and symptoms, you can end up being in the ICU, intubated with multiple specialists taking care of you. So I'm just going to jump straight into it. The way that we're going to talk about this is going to be using this board to go over the 5 ways, the 5 things that we need to look for when it comes to chest pain, the 5 reasons that I see people for chest pain most commonly. And the first one, you guys can probably guess it right because it has an H in it, and that stands for heart attack. Heart attack, heart attack. In medical field, we term this as myocardial infarction. And why this is very important is because if we take time and don't get it treated appropriately, don't get it treated soon enough, you can potentially die from it. You can have many complications from that heart attack. You can have things like heart failure. You can have valvular heart disease. You can have ventricular rupture where your heart leaks because that area that was weak is not getting enough blood flow, and it becomes weak enough that it can actually rupture. Time is muscle, muscle is life. If you're having any of these symptoms, these include chest pain, pain that radiates sometimes to the shoulder, pain that gets worse with exertion, pain that gets better with rest, or medication called nitroglycerin. We definitely want you to be seen in the medical field, whether that's in urgent care or in the emergency room, to potentially rule out this being a heart attack. This is the most important thing. If you're having chest pain, if it's brand new, if it's crushing, you're sweating, most important thing you can do is dial 911. If you can, if you have some aspirin, 4 baby aspirins, dialing 911. What we don't want you to do is drive. Potentially driving when you're having this ongoing heart attack, you can develop heart rhythm issues, which can lead to you passing out. You don't want to pass out while driving. You end up hurting yourself, hurting others. So first one is going to be heart attack. That's the most common, that's the number one reason that, we are cardiologists, but one of the biggest reasons why someone is having chest pain that I see them both in the hospital or follow-ups in an outpatient setting. Now the second one, C. Now this C stands for costochondritis. This is inflammation of the chest wall. Different from the chest pain from a heart attack, which is just external pain that radiates worse with exertion, better with rest, or medication called nitroglycerin. With costochondritis, they notice that whenever they change positions, their chest hurts. More importantly, how we figure it out in the hospital or in the outpatient setting is that we push on the chest wall cavity and they catch themselves. So this is inflammation of that chest wall cavity. So if you're having inflammation, the best way to treat it is with the anti-inflammatory medications, things like ibuprofen, if you can. Sometimes people may need things like steroids if they're not able to take ibuprofen. Because of existing medical conditions, issues with bleeding or issues with their kidneys. So costochondritis, inflammation of the chest wall cavity that is worse with certain positions, but also improves with certain positions also. The third one, this one we get called for a lot, and it's always interesting because of the way it presents itself, but starts with an R, and that one is reflux, gastroesophageal reflux disease, such as GERD. A lot of times, all of these issues are pretty much running in this area, so people will complain of that discomfort. What makes reflux a little bit different is that they notice it worse at nighttime, typically when they're laying down, or worse after eating certain foods, and it can be fatty foods, spicy foods, and things like that. Best way you can treat that is with anti-reflux medications, things like omeprazole, pantoprazole. But you also want to take care of this soon, take care of this early, because untreated can lead to a lot of complications. I've had a lot of patients have issues with bleeding over time when their reflux is not treated appropriately. It can lead to things like peptic ulcer disease. So definitely want to take those medications, avoid the food triggers, but also follow up with your medical provider. Sometimes you even need to be seen by a gastroenterologist, a stomach doctor, GI doctor. Now, the fourth one. This fourth one, I find that is one of the biggest ones that we really need to know about. And the reason behind it is that we see it a lot, especially if someone has had an illness, upper respiratory infection. And that one is pericarditis. So this is inflammation of the pericardium of the heart. So it's the outer layer of the heart. Similar to costochondritis, it does get better and worse with change of position. Sometimes people, when they lay back or lean forward, they can notice that their symptoms are changing drastically. Like costochondritis, this one is treated also with anti-inflammatory medications such as ibuprofen. But we also want to use a medication called colchicine because this is useful in preventing recurrent episodes of pericarditis. And I just thought about another one, and this is a big one. This one could potentially end someone's life if they're not treated appropriately and quickly. This one, they're having chest pain. It wakes them up from from sleeping, and they have low oxygen levels. This one is a pulmonary embolism. This is a blood clot in the lungs. There's a lot of different ways that it can ensue, but typically someone has a blood clot in the legs, known as a deep vein thrombosis or a DVT, and that clot travels all the way up from the legs into the heart, from the heart to the lungs. And depending on where it lodges in the lungs, can cause a lot of different issues, can cause a lot of life-threatening issues. So we definitely want to get it seen as soon as possible, because the treatments could be blood thinners, but sometimes people need emergent thrombectomies. They need to be seen urgently. So if you're having chest pain that woke you up, chest pain that is new for you, go get seen, especially if you're having difficulties breathing. And the last one is the most uncommon one, or not uncommon, unpopular one, unpopular one, and that is because unfortunately this one gets placed first way too many times, and that is anxiety. And I don't like that one. I don't like talking about this first because unfortunately people get labeled as this way too quickly, and what happens when you do this is that it prevents people from being treated appropriately, being treated adequately, to make sure that they're not having any of these other 5 potential issues. So anxiety can play a huge factor into it. And with anxiety comes with distress. How I typically label someone if they have anxiety as causing their pain is that I've ruled out the life-threatening etiologies. Immediately when they come into the hospital, we want to rule out heart attack, we want to rule out pulmonary embolism, because those ones can end your life immediately. There are tests that we can get to rule it out. Sometimes people may need a CT scan or heart catheterization to rule out pulmonary embolism and heart attack, myocardial infarctions, etc. But if those have been ruled out, then the history will point us in the right direction whether someone is having issues with reflux. History will also help us with pericarditis versus costochondritis. But when someone is coming into the hospital, we want to rule out the most dangerous things. And then if we've done that and it doesn't show up anything, it doesn't stop there. It actually goes from the inpatient to the outpatient setting, where we continue to work up to figure out whether it's, costochondritis, is it GERD, is it reflux, is it an ulcer, is it your gallbladder, cholecystitis, could it be your pancreas? There's a host of a lot of different things. And if those have been worked up appropriately and we don't find a cause, then you want to look at any potential psychosocial issues that may be causing this. Is it occurring during extreme stressful moments? Could stress be a factor into it? But I never want to use anxiety as the first one. Do your due diligence. Go get seen. If you're having any of these chest pains, if you're having chest pain and it's brand new, go get seen as soon as possible. My name is Dr. Isang. If you got any benefit in that, you're going to like this one about hypertension.